Okay, recording has just begun, and this lecture is going to be on the lower GI system. This is the PowerPoint out of the book. I'm sharing my screen with you guys. Want to make sure that you know how to assess patients with lower GI problems and causes and signs and symptoms, constipation, diarrhea. We're going to talk about inflammatory bowel disease. That's a big one. And inflammatory bowel disease is the umbrella term, which covers ulcerative colitis and Crohn's disease. They're both not fun, but just remember, of the two, Crohn's disease is the worst, okay? I'm not going to get really too much into abdominal hernias, but I will touch on them briefly. Absorption disorders I'm going to touch on because you definitely need to understand TPN, total parenteral nutrition, and when that's indicated and how it's managed. We'll talk a little bit about lower GI bleeds. I'm not going to talk about cancer in this lecture at all because there is a separate chapter on cancer. So when I lecture on cancer, I kind of go through all of the cancers at that point, and that's kind of down the road. So let's get started. So the lower GI system consists of small intestines. It's about 20 feet of sausage is what it looks like. And remember, DJ, ileum, duodenum, jejunum, and the ileum. So when we talk about opioids and the side effects, which are respiratory depression, urinary retention, paralytic ileus, we're talking about that part of the small bowel, basically seizing or freezing, okay? That's what a paralytic ileus is. It's the ileum, the lower distal portion of the small bowel that just kind of seizes up and doesn't move, no peristalsis. And the word peristalsis is the contractions. They're kind of like waves that go through all the small and the large bowel, kind of pushing the food through. When you're listening for bowel sounds, that's what you're hearing. You're either hearing food or liquid or even air that's moving through the digestive tract of the small and large intestine. Okay? The large intestine, which is also known as the colon, is the ascending, transverse, and then descending colon. When we talk about small and large intestines, understand the small intestines is where all absorption takes place. So in other words, you eat the food, you swallow the food goes into your stomach. All your stomach's job is to add the hydrochloric acid to break that food down into chyme, C-H-Y-M-E, which kind of looks like baby food, pureed. And then it leaves the stomach through the pyloric sphincter, goes into the small intestine. That's where absorption begins to take place. So all the absorption of the lipids and the proteins and the carbs and the vitamins and the minerals happens in that small bowel, small intestine, and kind of gets absorbed through the walls of the small intestine into the bloodstream, okay, and is utilized where it's needed. The large intestine, or the colon, is basically for the formation of stool, right? That's where that happens. As it's traveling through, the waste of whatever you've eaten mixes with water, stool is formed, moves along, and as it travels through, it looks like feces and then comes out through the rectum and then your anus. That always makes me laugh, sorry. Okay, what is constipation? Constipation means that there are feces that's stuck in the bowel and it's in the rectum, usually in the distal portion of the large intestine, and it's just not moving. And the longer it sits, the drier and the harder it gets. And when that happens, I can tell you from personal experience working in the ER for many years, every night there was at least one patient from a nursing home with impaction. And it would be like rolling dice. Whose turn is it to disimpact? Not me, your turn. So impaction is a problem. Older people do not have, number one, the thirst that we have. So they tend to not take in enough fluids. Not to the point necessarily of dehydration, but to the point where they have these harder, drier stools. They don't have the strength, to strain And if they do strain, they sometimes will initiate a vagal response, or they will vagal down. The vagus nerve, which is the biggest nerve in your body, actually ends at the rectum. If you strain to have a bowel movement, putting pressure on that vagus nerve, heart rate and blood pressure will plummet. So more people have heart attacks on the toilet than anywhere else in the house. Fun fact. How do we prevent constipation? Fiber, cellulose. Fiber, which is cellulose, is not digested. What happens with fiber when you eat foods containing fiber, or if you take, like Metamucil or a fiber supplement, travels through the digestive tract. And as it travels, it's grabbing onto water and holding onto water and bringing water with it. And so that mixes along with the feces, keeps it a little softer, makes it easier to pass. Okay. So when we talk about a high fiber diet, one of the best sources of fiber are fruits and vegetables, particularly with fruits, the skins of fruits. So like peaches, pears, when you eat them, the skin is cellulose, it's fiber, highest amount that you can really get, and that's what helps people move their bowels. And you also need sufficient fluid intake, and you also need to have a certain amount of exercise. You cannot sit all day long. Obstipation is the medical term for a prolonged constipation. Some medications can cause constipation. If a patient has hemorrhoids, or if a patient has rectal or anal fissures, which are painful. A fissure is kind of a crack in the mucosal lining of the rectum or the anus. Very painful, more painful than a hemorrhoid. They don't want to move their bowels because they know it's going to hurt, and so they tend to wait, and then they get constipated, right? And then, of course, a low intake of fiber or fluids, they're all contributing factors. Signs and symptoms of constipation, I mean, you can read that, abdominal pain, belly is distended. You will hear their intestines being hyperactive. You would think hyperactivity in the bowel would mean increased peristalsis and diarrhea. Not always. Hyperactivity in the bowel, when you hear hyperactive bowel sounds, there's a lot of air in there and things are trying to move, but when they get down the descending colon to the rectum, they kind of like, stop. Because once that stool gets hardened in there, it's not going anywhere unless you go in and take it out. Okay. Complications, really the one I want to talk about is impaction. And, with impaction, and again, happens with older people a lot, you will see them have a smearing sometimes of a liquid stool. And, especially in nursing homes. I hate to be a hater of nursing homes, but it is what it is. I'll see documentation, patient had small BM, like a smearing. That's not a BM, right? A smearing or, a little smear of a liquid stool can really be a big indicator of an impaction, because what's happening is they're still eating. And so stool that's up higher than the impaction is still kind of liquid or semi-liquid. So it's oozing around the impaction and kind of oozing out. So beware of that, okay? Therapeutic interventions, we really should be taking in at least 2 to 3 liters, 2,000 to 3,000 mils of fluid a day, as long as there's no contraindication. You can read the therapeutic interventions, stool softeners. Of all the drugs that are out there, including things like Tylenol and Advil and everything, the safest drug on the market is docusate sodium cholase. It is not contraindicated with any diagnosis that I can think of. Post-op patients, I put them on it all the time because all it does is keep the stool soft. You want to beware of fiber supplements for older people, especially if they're sedentary and if they're not drinking much, because the fiber supplement can actually have an opposite effect, right? It can actually make them more constipated. In order for fiber to work effectively, they have to be moving around and they have to be drinking. Remember that, okay? Listening to bowel sounds, and remember, whenever you're examining a patient, when it comes to the abdomen, look, listen, feel. Look at the abdomen. Does it look distended? And do you see any scars from previous surgeries, that type of thing? Listen, you're listening for bowel sounds. When you are listening for bowel sounds, I don't know if you can see my belly. I hope you can. But the umbilicus is kind of like the center point, and you divide the abdomen into 4 quadrants, and you're going to listen to each quadrant. If you don't hear anything, you must auscultate with your stethoscope for a full 5 minutes per quadrant. 5 minutes, 5 minutes, 5 minutes, 5 minutes. Okay? So upper quads, lower quads. Diarrhea, I mean, there's not a whole lot for me to say about diarrhea. It's the opposite. When we talk about diarrhea, make sure that we are clear with patients as far as what diarrhea means. So if the patient says, oh, I had diarrhea this morning, my first question is, how many times did you move your bowels? And was it liquid, semi-liquid, semi-formed, or formed? Because if they moved their bowels once, but it was kind of liquidy, well, maybe it was something they ate. They moved their bowels 5 times this morning, well, that's diarrhea, right? And they can get dehydrated very quickly. Signs and symptoms, fever, foul odor, especially with C. diff, smells delightful. Anybody that's ever smelled C. diff knows doesn't smell like anything else in the world. Therapeutic interventions, what made it happen, right? If they're dehydrated, replace their fluids and electrolytes, possibly increase their fiber. Diphenhoxylate is Lamodal. I don't really get into it that much because I've not seen any questions about it on ATI or the boards. But loperamide, which is Imodium, over the counter, right? I think everyone's heard of Imodium. Can be used, but should never be used. So Imodium should never be used if the patient has or has a history of any intestinal obstruction or any type of intestinal cancer. And it should never be used for more than 2 days. So in other words, if somebody's still having diarrhea, they need to go see a doctor. They can't just keep on taking Imodium, okay? Probiotics, which they talk about Lactinex, which is one, are basically a supplement of the good bacteria, right? They are wonderful if you are taking an antibiotic for bacterial infection. That antibiotic, as we all know, can kill bad bacteria, but it can kill the good bacteria too that you have in your gut. So probiotics can be helpful. A better choice is to eat yogurt with live cultures in it. That's the nature's natural probiotic. So diarrhea can be caused by utilization of antibiotics. Let's see. All right, enough with diarrhea. I do believe appendicitis. Okay. Your appendix is an itty bitty, probably the size of your thumb, maybe even a little bit smaller. Little bitty appendage. It's considered a vestigial organ. What does that mean? We believe that at some point in our development, back when we were cavemen and women, that appendix did something, like we needed it for something, but we don't need it now. So your appendix is kind of like your wisdom teeth. Wisdom teeth are vestigial. We needed them when we were cavemen and women because we were eating things that were raw, right? So we needed that extra chewing power. Your appendix now, it doesn't do anything. But its location, which is right kind of where the small intestine, the ileum, meets the ascending colon, large intestine, at the cecum. The problem is that sometimes if it gets irritated, fecal material can get stuck in the appendix. When that happens, the appendix can start to become inflamed, irritated, and the patient can develop appendicitis. If they do develop appendicitis, here's the problem, and it's not treated, the appendix can actually rupture. That's a very life-threatening condition, rupture of the appendix, because that means that the fecal material and that infectious material and the toxic waste also that's in the bowel right there all now spills into the peritoneal cavity and can cause the patient to get septicemia, go into septic shock, and even die. One of the biggest signs is pain, right lower quadrant. You need to know McBurney's point, okay? And McBurney's point is, I want to make sure that you all can actually see me while I'm showing you. So, McBurney's point, you find the patient's right iliac crest and the patient's umbilicus, and it's midway between the two. Right lower quadrant, it's right there. That's McBurney's point. If the patient has pain,
Miss Mary,
yes.
I'm sorry, I don't want to cut you. Can you pull your face down? Because I see you the same exact way. Can you pull your face down onto like the things? It'll make you bigger.
So, but I'm trying to show you my abdomen.
Yeah, we can't see you. You're like a square in the corner.
Oh,
If you click on her and hold it and drag it to
on
your
your
main
face
screen.